Hello, this is Brock Bradshaw, SRNA. Need to call report on a patient coming to you guys. If I could, please get your name and title. Thank you. So we got a 55-year-old male, 97 kilos, approximately 189 centimeters tall. Significant medical history for sleep apnea, hypertension, renal insufficiency, hypogonadism, depression, insomnia, and back pain. Patient did recently undergo a excision of his squamous cell carcinoma. That was of the neck and the lip. This was 3 months prior. And then there is a history of, not exact, but history of anabolic steroid use. And then associated with that surgery 3 months ago, he didn't claim any anesthetic complications, and we don't have any anesthetic records from that case exactly. Allergies listed for penicillin, sulfa drugs, prednisone, and steroids, for which he claims they cause violent hiccups. Procedure, kind of diagnosis and procedure we're doing is a right hemithyroidectomy for treatment of his squamous cell carcinoma. Preoperative labs were insignificant. Preoperative vitals were within normal limits. He did have a serum creatinine listed for 1.7, a GFR for 44, and then a blood glucose for 120. Of note, within the medical history, as far as his medication history, it was said that he did take his valsartan the day of surgery. Kind of moving in preoperatively medication-wise, we did dose him with 20 milligrams of Pepcid. He did get 4 milligrams of Zofran. He did receive a 1.5 milligram scopolamine patch behind his ear, all in kind of efforts to manage his perioperative nausea and vomiting prophylaxis. He did also receive 500 milligrams of Tylenol for analgesia, and then a 2 milligram of Versed. Looking at my assessment, specifically my airway assessment, I did find that he had a Mallampati class 2 airway. He did have intact dentition, as well as he had limited neck extension due to his previous neck excision. His physical status score was a 3. As far as kind of interventions, we did provide him with an 18 gauge PIV to the left hand, as well as a 20 gauge peripheral IV to his right hand. Throughout the case, we did provide him a Foley for accurate outputs, and then we utilized regular blood pressure and hemodynamic monitoring with also the addition of a BIS to kind of monitor his sedation. For specifically our intubation, we utilized 100% oxygen for 2 minutes. We did provide general anesthesia medications with 150 mics of fentanyl, 80 milligrams of lidocaine, 5 milligrams of rocuronium, and then throughout he had 140 of succinylcholine. And then he also had 200 milligrams of propofol. We did tape his eyes shut. We provided oxygen and then a sevoflurane gas for via mask ventilation for about 1 minute. We were able to visualize with a video laryngoscope his vocal cords. After the initial pass, he did have some coughing despite all the sedation that he had received. And so we did give him an additional 50 of propofol. And at that time, we were able to successfully intubate with a 7.0 ET tube. Myself and the surgeon, we did confirm with the video laryngoscope that the ET tube was placed appropriately, and then we were able to switch him over with the oxygen and then the desflurane gas to achieve an end-tidal CO2 concentration of 6 to 6.5%. Kind of moving on throughout the case, as far as significant events that occurred, he just had refractory hypotension, and this occurred primarily about 20 minutes after intubation. We had a blood pressure reading of about 70/40. And so at that time, he was unresponsive. We were managing his blood pressure with ephedrine and then phenylephrine pushes, as well as we had given some IV fluid boluses. He was still not responding to those, so we had actually, stopped his propofol infusion. We had lowered his desflurane gas, as well as we gave a gram of calcium chloride, and then we had switched over and started giving some vasopressin pushes, for which he was responsive to. We were able to get his blood pressure map above 60 at that time. He still was having some labile blood pressures, and it was then that the surgeon had remembered that he had actually had a history of the anabolic steroid use, for which I think the last dose he had claimed was about 6 months ago. So we did, despite his allergy history to steroids, we decided to give him over 10 minutes, we decided to give him 100 milligrams of hydrocortisone, even knowing with this allergy, and his blood pressure after that was able to kind of normalize. So throughout the case, we did give a total of 2.5 liters of LR. He did get 25 milligrams of Benadryl, 100 of myxofentanyl. He got a 1 milligram dose of Dilaudid. We did antibiotic-wise treat him with 900 milligrams of clindamycin. We had utilized a propofol drip for some time, and then whenever he became hypotensive, we had given a ketamine of 40 milligrams of ketamine, along with he did receive the 1,000 milligrams of calcium chloride. We were managing him with ephedrine and phenylephrine pushes, as well as vasopressin pushes. And then he got in total for steroids-wise, he got 100 milligrams of hydrocortisone. So after having given him that hydrocortisone, and then I guess our current state vitals for now, he's 115 over 64, pulse of 66. As far as total urine output for the case, we only got was 75. As far as immediate post-op needs, he'll be coming to the ICU. We'll leave him intubated. He'll be needing to be monitored for blood pressure needs. His hemodynamics will be needed to be monitored closely, as well as urine output. As far as kind of plans for extubation, we're going to let the ICU, the critical care team, manage that, and that'll be pending on his hemodynamics and then monitoring for bleeding post-surgery. We'll shoot for a goal map of greater than 65. We also want to monitor any adverse reactions from the steroid use. As far as post-op consults will be the critical care for the hemodynamics and then potential for vasopressors. We'll also consult RT for any ventilator management and possible extubation. We'll need to consult PT and OT for any, once he is, getting closer to being ready for mobility, and then making sure that his strength, his mobility, and then ambulation, and then his ADLs will be able to be completed by himself appropriately. And then lastly, we can consult a nutritionist just to be sure that if there are any dietary modifications that he will need to be made, he'll have that information provided to him appropriately. So we'll get him up to you guys within the next probably 15 minutes or so once we're wrapping up the case. Thanks.